We're so excited to have this very special guest speak to us on teletherapy in a post-COVID world. And so with that, just wanted to briefly go over the agenda today with regards to this webinar. We just got a short introduction to make, and then we'll jump right into this presentation. Again, we're running just a couple of minutes behind with this. And then at the end of the presentation, we will have a question and answer. So be sure, we've got here in Zoom, we have the chat functionality. Be sure to leave us your questions in the chat, and then we will address each and every one of those as the presentation concludes. So without any further ado, just wanted to briefly explain who we are. We are eLuma, and we do online therapy for K-12 special ed. Specifically, we focus on speech, school psych, mental health services, counseling, assessment. We do occupational therapy, physical therapy down the line. We've been around for about 10 years, and we have well over 200 team members working with schools and districts all over the country. That number actually needs updating. We just crossed the 20,000 student threshold, so we're working with a lot of students trying to, students with disabilities, trying to help them make their lives better. This webinar is part of our ongoing Illuminated Special Education series. We focus on teletherapy, and want to make it known to everyone, we're going to be recording this event. And if you would like a copy of the recording, just let us know. We'll send it out to you. And then above and beyond that, we'll send you the slide deck as well too. Without any further ado, I want to just talk a little bit about Ellen and who she is. I've been an admirer for some time. She is a renowned professor, a researcher, and administrator in the world of telehealth, telemedicine, telerehabilitation, whatever you call it. She's coming at it from the perspective as an academic. She's worked at the University of Pittsburgh. I believe she's an adjunct professor for some time at the University of Maryland. But she is very skilled and knowledgeable in the field of innovative program development, distance education, communication, health and rehabilitation curricula, multidisciplinary program direction, communication science and disorders, a whole bunch of things. Above and beyond this, somehow, I don't know how, but she's found the time to be the editor for the International Journal of Telerehabilitation, and is the past director of the American Telemedicine Association. So without any further description, let's jump into the presentation. Ellen, I'll go ahead and man the deck for you, and you just let me know when you want the slides changed, and we'll continue on that basis.
George, I appreciate this overly generous introduction. And you all gave me the title, Why Teletherapy in a Post-COVID World? It's going to be a new normal for sure. COVID and all those challenges have stimulated our creativity, and I don't believe that teletherapy is ever going to be the same after COVID. So that's kind of a good thing that's happened. We'll push the next slide. Okay. George, can you? Good. Okay. So first we're going to talk about terminology, because it's just important for us to be on the same page about that. Next slide, please. So what is it? It is telehealth is a service delivery mechanism. It's not therapy. What we're doing right now, we're online and we're talking via telecommunications. The client is usually in a different location than the practitioner, although the physical location can be in a different room in the same clinical facility. That's how some people practice telerehabilitation. I'll revert to teletherapy as a term as we move ahead. It could be across the street. It could be in a different city, a state or country. It could be at sea, in a plane. There's a lot of it that happens in a plane during an emergency, and it's in outer space. So next slide, please. So here's a picture of a really pretty home in Pittsburgh. And I'm in New Jersey now on the shore, but I spent many years, almost 35, 40 years in Pittsburgh. And they have these beautiful homes, and they all have steps going up. And the winters aren't so great in Pittsburgh. These steps in a month or so will be probably covered with ice. People can't come down easily for an appointment. They break their legs, they break their pelvises. It's just a mess for someone who's elderly or who has a broken leg even. It's really awful. So with, even in a city setting or a suburban setting, teletherapy is very helpful. And so it can happen in the most normal of places, not necessarily in some isolated part of the world or in outer space. Next slide, please. So why do everyone seems to call it tele something, and it's important to know the differences. I believe a lot of you are special education supervisors, and so it helps to know what other professions call it. Well, it became pretty prominent from telemedicine. That was the first start. So the American Telemedicine Association was formed, and they formed all these different subspecialties because of the demands. For example, teledermatology, teleradiology. Lots of our radiology right now has been done for years with maybe a radiologist sitting in their basement getting our films sent to them. ICU work. Neurology is really big, teleneurology. If someone has a stroke and these outlying hospitals don't know whether it's a good idea to administer the medication for it, neurologists I know are on call. Psychiatry is really coming along. Pediatrics, primary care is harder to do, but there's now with COVID, a lot of it's been happening that way. Telenursing's been an old discipline. Dentistry is a little tough to fill a cavity, but it's still, there's a lot of uses for teledentistry. And then we have telerehabilitation, which covers occupational therapy, speech therapy, a lot of different rehabilitation disciplines. So that's how, the American Telemedicine Association embraces the term. Telehealth refers to just health pretty much, and that is the American Occupational Therapy Association has adopted that. So telehealth. Whenever I publish with someone from telehealth, often Jana Kaysen, she wants us to call it that in the article. Telerehabilitation, as I mentioned. Telepractice is an unusual term. It's been adopted by the American Speech Language Hearing Association because of the fact that a lot of clinicians work in the schools, and it may not have anything to do with health, what they're doing. And then teletherapy is emerging, I believe, as a term with special education. I really like that term, actually. So we can do the next slide, please. So again, why did ASHA choose telepractice? Because I'm an SLP. I've worked in medical and non-medical sites. The school-based practice, it's an umbrella. It encompasses educational practice, rehabilitation, and also medical and health conditions. So many schools are able to bill Medicaid, and that's a source of income. So within telepractice, people refer to telespeech, teleaudiology, and then there's something new that I've been working with to try to get this emergent, and it's called tele-AAC, where those of you that have students that are using augmentative and assistive technology, like Stephen Hawking's used, or even an iPad, that refers to tele-AAC. Next slide, please. So ASHA has specific definitions. Why is that important to you if you're a special ed supervisor? Because it has to do with how students are allowed to practice in the site, how clinicians are allowed to train students. So it talks about linking the clinician to the client, and it sort of has a sense of like synchronicity, like it's happening at the same time most of the time. What's not telepractice is supervision. Okay, so let's say as someone is having what's called their clinical fellow year, and they have to be supervised. And you've probably tried to hire people in that situation. You have to get them a supervisor. There's been issues about supervision. Now, ASHA has relaxed that, allowing for telesupervision, but June 30th, that's going to revert unless it's changed. So let's do the next slide, please. Now, why is this a problem? Why all these inconsistent inconsistent nomenclature? It really shows that it's a nascent kind of development. Okay, when the terminology isn't secure yet, it shows that things are still changing. It does perpetuate professional silos. It's really awkward when you're advocating your legislature for reimbursement. People who are drawing up these bills are putting in like 10 or 15 different descriptive titles for what's happening: telehealth, telemedicine, e-health, mobile health. You want everything to be covered. And it's really important because a while back in Congress, there was a misplaced comma, and this desperately affected reimbursement for SLPs and for physical therapists. So then we also have, maybe some of you are writing an article or a grant proposal, and you've got different professionals on the roster. Well, whose terminology prevails? Usually the first author's terminology prevails. Next slide, please. Okay, so now there's also some other basic terminology: asynchronous, not happening at the same time. So that would be store and forward, where someone does an examination, sends it to someone else at a distance to evaluate it, maybe sending test results. It could be by email, it could be a recorded session. Right now we are synchronous, we're going on at the same time. And then there's the term hybrid, and that's kind of an emerging term in terms of importance. It has two meanings. It could be a combination of asynchronous and synchronous with a client, or it could be a combination of synchronous and asynchronous and in-person care. Okay, so the first part of it is where you're seeing a client and you're seeing them in person on the video. You're seeing them on the video, and you're also maybe sending emails and records. The second one is where you're doing that, but one or both of those, and you're seeing the client in person, or the student. Okay, so those are some different meanings. Why is that important? Well, when people are doing research, we have to know what they mean by hybrid. Next, please. Next slide, please. Thanks, George. Okay, so now in person, that term's been used badly. It means, well, actually, in person's okay. It means in the room where it happened, taking, the Hamilton definition, okay, being actually in the room. That's called in person. But it's face-to-face that has been confusing. We are face-to-face now. I can see you, you could see me. Some of you have your pictures up. Not too many of you are live right now, but it's considered face-to-face. We could potentially see each other's faces. It also could mean being in the same room, and that's why it's confusing. We don't use that term anymore. We use in person if you're in the room where it happened. We're editing out the face-to-face one. Okay, next slide, please. Let's talk about how telehealth became adopted. What's some of the history behind it, without being boring with a lot of history. Okay, this is a real quick snapshot. Next, please. So in 1924, the radio doctor was predicted, and that was kind of the first indication of telehealth as a possibility. Next slide. And then, of course, we had any of you that are Trekkies, early telemissions to boldly go where no teacher or therapist has gone before. Our space program was taking vital signs from astronauts early on. I mean, in the 60s, they were doing that. They knew what the blood pressure was of astronauts, and that was telemedicine. Moving ahead. So now it really advanced with the military. And I guess about maybe 10 years ago, at the meetings of the American Telemedicine Association, you'd see, tens of scores of military folks in their uniforms presenting information. They were really important to this development. And so they help they're really interested in wounded soldiers, wounded warriors. If someone gets wounded, they want to get them help immediately, right there on the battlefield. And I have a friend who's a retired colonel that's working on grants to have very advanced work, advanced help for these individuals. It's remarkable. Robots and diagnostics and help right there on the battlefield. It's also, the military is also using telemedicine to help civilians when there's a natural disaster. So the military, we don't hear so much about it if you're outside the military, but they are the pioneers in what we're doing now. George, next. So now, this is not very happy news. Right now, telehealth reimbursement is not yet robust, and it really varies, okay, what state you're in. The federal government is different for different disciplines. Medicaid is usually is coming along as a payer for states. And this is really a good reason to be affiliated, do your work with a company. To have, it's really burdensome for a staff, a school staff, a hospital staff, to be actually the ones who are supervising or doing the therapy, to have to be involved in this reimbursement stuff. It takes a lot of expertise. And so people don't realize how much effort and time a company puts into getting reimbursement, and not having a situation where you're afraid to see a student because you don't know if they'll be reimbursed. It's a gift as the therapist to be able to see a student knowing that that's covered by a contract. Those were the good old days, and I think it's coming back to that. So now if you want some up-to-date information, at least from the speech pathology standpoint, I've given you a website. ASHA updates this, American Speech Language Hearing Association. They'll give you information for different states and for and legislation that's coming up or has just gone through. They do a pretty good job with that. George, you probably are involved a lot in reimbursement, right?
We're working on it. Obviously, it's of high interest to a lot of schools and districts out there. I heard from a special ed director once that they had seen in a presentation that only 57% of available funds were actually accessed and reimbursed out there, and it's obviously a tricky endeavor. A lot of people don't have a defined process. A lot of people, and it varies from state to state. There are a lot of challenges with getting that full reimbursement. So yeah, it's a big thing because obviously we're trying to get, the students as much services as we possibly can. And it's always a challenge to get it paid for.
Yeah, it's not an easy thing, and it should get, that's one thing we hope will get better post-COVID, make it easier. So now, there were tipping points to tele. For a long time, we were talking to ourselves, those of us that were presenting at conferences. There wasn't much going on, but we knew that there would be tipping points when we saw this innovation start to become acceptable and diffused, and COVID has caused a tipping point. Next slide, please. So let me tell you about a model for this. I remember this. Okay, I lived in New Jersey during 1978, and there was like a really, we had all these ATMs that were put into place. That's something we all use, right? Most of us use it to get our money right now. But then there was a lot of hostility towards them. They were called holes in the wall. Next slide, please. We were saying, well, why would we take a job away from our tellers? We love our teller. We go to the bank and say hello to them. They give us cookies at holiday time. We didn't want to hurt the bank tellers, and we didn't trust that machine. Like, how does money come out of it? How does it work? How do you register your card? It's amazing, something we're used to right now. We just put it aside and didn't bother with it. Okay, George, next one, please. So, what a difference a day makes. Okay, the storm clouds were gathering. Okay, I mean, there was a big storm coming in. The seagulls left the beaches. Something's happening. Next slide, please. So February 5th, we were struck with this huge blizzard. It's no joke. It's true. The city was paralyzed. 15 feet drifts, 20 inches in some places. People were stranded, and they were stranded in hotels in New York City. Next slide, please. And so people died in the storm. It paralyzed everything. And one thing that happened was that the banks closed. there were people, the news showed people banging on the doors of banks wanting their money. The staff, had gone home early. They couldn't open the bank. So people were stuck without food. They were stuck in hotels. Some of them, didn't have their credit cards. It wasn't as used, they weren't used as much then. And people were pretty angry. Next slide, please. So it's my money and I need it now. I mean, people were mad. Next slide, please. So what happened was that an enterprising vice president in Citibank, went and put an ad on TV showing people banging on the door of the bank, and then someone, pushing their card into the ATM and getting money out. And this was a big shift. People, everyone, I remember myself, I better figure this card thing out. They advertised that your Citi card gives you a key to the bank. Are we kidding? We're not kidding. The city never sleeps. Okay, this was a shift. ATMs became very much important and used. Next. So lots of us were thinking, well, could a pandemic be a tipping point for a wider use of teletherapy? Yes, and I was considered a little weird at this point, but in 2007, I gave a talk about it, okay? And in 2008, I gave another talk about it. And people were starting to say, yeah, that if we ever had a pandemic, we're not wishing for one, but if we had one, this would be a tipping point for telepractice. Next slide, please. So one thing I read, and I really advise you to read it if you're in any way interested. It's a pretty thick paperback book. It's called The Great Influenza, and it details the evolution of the 1918 pandemic and things that people did that weren't helpful at all, like putting plastic around their houses, which intensified the virus inside. It was really serious, and people were dying who were in their 15 and 40 years of age in Pittsburgh. Really, it wiped out a lot of this incredibly talented population in their 40s. And children were left as orphans. And I could see reading that this was a long-term situation. I actually am a result of this pandemic. My grandmother was engaged to an optometrist who died in the pandemic. She remarried my grandfather, and then my mother tricked him into having her. And I say my grandmother tricked him into having my mother, and that therefore I was as a result born as a grandchild, and I have brothers and nieces and nephews. I'm a result of the pandemic. It's creepy to think about, but so maybe I was a little bit more interested than others in it. Okay, next slide, please. So we do know, however, that things happen that aren't so good in every generation. And just to give you a sense of perspective, I was 4 years old, and I remember the adults looking out the door and going, there's Sputnik. Sputnik was the first satellite, was launched by the Russians, and people were terrorized about it. And then in 1962, we were diving under the desks for the Cuban Missile Crisis and saving a lot of food, and it was very scary. Those were tense days. And then most of us would remember where we were when the Challenger blew up. And then, of course, we have 9/11. So we can go for many years with things going pretty nicely, but things happen. Next slide, please. So what just happened? Okay, well, we had some indication of this in January. We were told that there was a mysterious respiratory illness in China, in Wuhan. And then we started to see public alerts. And those of us who are used to having things happen, and my colleagues in emergency medicine said, this isn't very good. And we started telling our classes, like in early February, we may not be able to see you after spring break. This is how we're going to do it. And all of my online distance ed classes have always been, well, let me say this, my in-person classes have always been convertible to distance ed classes because I've used like Blackboard or Canvas. So that's one thing. If your content in the future, whatever it is, can be converted rapidly in case of snow day. I hope we don't see another pandemic. These are things that some of us have had the mindset to do. Next slide, please. So we made anticipatory preparations. Stephen Colbert, many of you watch him, he figured this out pretty early, and he told the staff, get ready to broadcast from home. Lots of us, when what Lysol, those Goya chickpeas, too many of the, I don't know, Costco was pushing them, so lots of us still have a lot of that. We figured out we better get our computers at home. And if we can't do that, if we're not allowed to, I mean, I bought new computers actually. Toilet paper is always an issue with anything that goes on. And we had the feeling that our offices would be closed. So anticipatory preparations are good, no matter what, even after post-COVID. Next slide, please. What happened was that COVID-19 turned on the telemedicine spigot. And man, it was really hard to drink from. But there were a lot of things that happened. Mobile apps were used to assess, like FaceTime kinds of things to assess signs and symptoms. Lots of us are enrolled in like mobile apps that allow them to do contact tracing. Artificial intelligence governs that. There's biosurveillance, which is happening. Even looking at the sewer water to see if a building is infected or not with, the people in the building. So people on the good part of it, public transit wasn't being used as much unless you got your job that way. And therapists were at home and they wanted to work. So, and we're ready to work. Very creative teams. Next slide, please. So now let's move ahead to some foundational content for you all. Okay, so what happened was a paradox emerged. Okay, two things, one positive, one negative, can be held at the same time. Next slide. And this recently came out like last week. This is from the International Journal of the International Society for Telemedicine and Telehealth. It's a free journal. It doesn't have a subscription. Great articles. And this time they put in an editorial that said, look, COVID-19 has given promise to teletherapy, but also peril as well. So what's the promise? Well, vendors are real excited about this. This is a huge market, a $600 billion market by 2026. So you can imagine, they're just waiting to go to conferences and contract with companies. The World Health Organization said, look, member states, we want you to adopt eHealth because they saw that as a way to reach underserved folks. eHealth became really valuable for addressing mental health issues. They were looking for clinicians, they were understaffed. And the promise is that we know it saves time, okay? And for some organizations, it can save money. And what are the perils of it? Well, opening up the floodgates may not be wise. What about policy? The policy is always lagging behind the technology. Who's deciding the policy? Businesses, consumers, states, governments. It's real unclear right now. The evidence base is looking pretty good, but in some cases it's equivocal. And as a journal editor, I can tell you that I'm getting an onslaught of articles right now about telepractice, but they're terrible. Some of them are just terrible. People are at home writing with too much time on their hands, and the articles have not been good. And no one sends in negative results, like this didn't work because of this reason. They're only sending in positive results. That's how people get promoted in academics. So the evidence base is equivocal. But for what you're doing in schools, it looks pretty good. So the cost benefit analysis, it's lacking in low and middle income countries, but it's looked helpful for higher level entities such as schools. It's to the benefit of schools and health systems. Next slide, please. So now, what are the issues of concern? Well, it could be profit-driven versus client-focused. Clinicians of my ilk tend to be very client-focused. The state requirements are often self-serving. They're trying to keep people out of their states, and they've been difficult to deal with. Keep teletherapists from other states from working in their own states. There's a lot of potential for fraud and abuse. That happens with Medicare, Medicaid. And, in my field, hardly anyone comes up for ethics charges except when they're defrauding Medicaid. It may not address the original mission to reach the underserved. And we really want that to, stay in the focus. Now, this would be really bad if it was used to avoid traveling to a network, to a different neighborhood. I've heard people say, I don't want to go to that neighborhood. I don't want to be with those people, or there's gangs there in the afternoon. I don't want to go there. Let's work with telehealth. So, it could be used in a discriminatory fashion. To be honest, it's caused layoffs of in-person clinicians, and many of those people have retooled to become therapists online. The training right now is very nascent and unregulated, and people are claiming they're giving out certificates for 6 hours of work. It's not a certificate or certification. These are given by organizations and universities. They're not, so don't be spending your money for $200 or $300 or $700 thinking you're going to get a certificate that is meaningful. Often they're terrible. The professional codes of ethics are not well developed. They will prosecute people, but not organizations. And the states that will adjudicate some of this, they're looking for profit. If they can't get money in a fine, they're not interested sometimes. Next, please, George. Okay, but most of the things you worry about never happen. So I think there's still a very positive outlook. Go ahead, George, thanks. Okay, so now, as we talked about, it's axiomatic that technology evolves faster than policy and regulation, training, professional trust, consumer trust and action, and resources and payers. Now, I put a picture up of the vaccine, getting a vaccine in the arm. This is a great example of the problems that have faced telehealth. Next slide, please. So now the environment's really complicated. And this is, you might say, why do I need to care about this? Well, most of you are employed by a school district or a hospital setting, perhaps. And, you have to think about, what the status of that particular district is financially. We're influenced by state licensure boards. They tell us what we can do. You have to keep up on that. They could change really fast. And then there's national state boards. The professional organizations demand certain things of us doing telepractice. Some of them have not helped at all. Professional trade associations are becoming very influential. A lot of money in there, American Telemedicine and HIMSS. The federal government, each of these entities have put out reports. Congress, CMS, FCC, FDA, they put out reports and making all kinds of recommendations, but they haven't funded moving this ahead. The state governors have also been interested in this for over a decade, and the state legislative bodies. And then what was really kind of sobering was that we started to see a K Street lobbyist. We saw an amalgamation of companies that came together and they wanted to raise money and influence legislators. And then we knew that this had really shifted. Okay, this became a big business. Next, please. So Scott and Mars, who wrote that editorial, said, look, curb your enthusiasm here. There's a fire hydrant with regular and sparkling water, and there's some really great things about telepractice and some that aren't as good, and you have to be cautious about it. They even talk about making it environmentally sensitive. Okay, next, please. Okay, so now we learned a lot of lessons watching the past. One is what can cause a lot of change in your jobs, your professions, and what would change it? Like, what would a disruptor be? See, George, we're not seeing the whole slide, but but I can manage it. So like what happens, thank you. So like, what are some external influencers? Well, I mentioned your community, your economics of the community. Are they if the schools are funded by property taxes like they are in New Jersey here? What's the status of that? Here on the coast of New Jersey, they've given people tax abatements to buy homes, and therefore their money is not going in to support the public school system. There are, of course, natural disasters. We all plan for those snow days. Well, those in climates like this. Climate change is something to think about. We have terrorism. It's been obvious in now, on several occasions, even in the school. And then the pandemic. So you have to think, what could the disruptors be, and be prepared to have plans if that happens, to turn on a dime. And then there's the internal influencers, which are our professional standards. If we're getting trained in the workplace, how about, are we getting trained in the, by our professions? There's some things that would be very good. Like, let's say science, was able to eliminate disabling conditions. What if stuttering was no longer there? We wouldn't have as much need for therapy. On the other hand, we have recognized disabling conditions such as the impact of swallowing, dysphagia, on health. So, we're going post-COVID, we're still going to be, subject to conditions of change, and we have to be aware of what they could be, and, be prepared to make changes. Next slide, please. So a potential disruptor is artificial intelligence. I'm not going to go into this. It's not my area of expertise, actually, but I want to say that the leaders in the field that have predicted technologies, they're really looking at artificial intelligence. This is using algorithms to predict what the needs will be, how to cure different things. I'll just give you one example. Let's say you're in your car in the future. Maybe it's a self-driving car, but let's say you put your hands on the wheel and it measures your temperature and measures your blood pressure and your heart rate. Maybe your seat can weigh you. And then whenever you're moving away from your standard baseline, it may notify your healthcare practitioner saying, Ellen is going into the yellow zone, and then they call me up to try to make adjustments and save money in terms of their insurance. So AI is going to be huge, and it's always already being applied a lot in the Mayo Clinic. Next slide, please. So now the proverbial horse has left the barn. Okay, after COVID, teletherapy is going to be here to stay. People who've been working with it have become really creative and done some great things. But how's it going to develop? Next slide. So now, part of the development has to do with motivations, and one is altruistic, providing service to clients who would otherwise not have service. And I have a sense of that from eLuma, which is why I'm here today. The consumer is motivated. It saves time and money, and they don't have to leave work. They can be seen any time of the day or night. The clinicians, good for clinicians, the workforce, maybe they want some flexibility. Some are part-time, some are full-time. It could be they're learning new skills. So clinicians seem to be clamoring for training. Organizations, for sure, it's saving money, generating profits. When they have a contract with a company like this, it is, and also if they're doing it themselves, it's avoiding cancellations. 10% of cancellations could be a lot of profit for a hospital. And then society, there's societal motivations, saving time, it's saving health, mortality, morbidity, money. It provides service to remote locations if there's an internet connection. Health disparities can be eliminated. So there's some really great motivations for teletherapy that operate at the same time. Next slide, please. So now I don't have to tell you that students have returned to home for schooling, and some have come back after being at home for a while to school. So there's so many different permutations of what has been happening. Next slide, please. So now a good thing is for there to be customizable school-based options. And I had queried George about this, how does eLuma operate? And I started to go through these models. He said, yeah, we do this, we do that, we do that. There seems to be a lot of different variations that can be customized to a school or a school district. So the traditional model was the district hires and employs all the personnel. In an augmented traditional model, the company is helping out, supplying personnel. That costs money and time to find people and vet them. The company is filling in some staffing needs. In schools, a lot of teachers, are moving in and out of family leave situations. The company can provide consultants. Okay, like what are your needs as a school district? And then there's a subcontracted model, and that could be traditional or hybrid. There was one school in New York where all of the therapists were supplied by a company in the school. And that didn't work out so well. It wasn't this company. They weren't prepared to have a workforce that large. And then another subcontracted model is total telework, where the client is either at home or in school and the therapist is at a distance. So these are great. The fact that there's such great options is really important. Next, please. So now a basic fundamental issue is that if you know one state, you know one state. Okay, next slide. This may not be the case for many of you here, but if you're an SLP, you need to have a state license in the state, most states, except if you are working in the VA or Department of Defense. And that means you have to get a state license, and it costs money, and there's time involved, and the requirements change rapidly, and they're sometimes annoying and difficult to do. You have to have the license where you are as a practitioner and where the client is, where the student is. So, it gets to be expensive. And some states don't have regulations on telepractice, so you need to contact the licensure board. And the malpractice insurance carrier should be contacted to be sure that the malpractice insurance is covered if you're working with a client in another state. The good news is that state licensure compacts are developing. That means that one license works across the country, or at least for the states that are in the compact. It's gone quite well with the medical professionals, 44 states. I think that ASHA has about 6 states right now, and they need 10 states in order to become a compact. Nursing has probably, last I heard was about 22, and it's over a decade. So unless Congress comes and says, look, licenses are going to be good across the board, I'm not excited about the compacts being helpful for huge numbers of people. It's unfortunate, but again, states want their income, and they may feel that they're not getting the income from different licensures candidates if they go to a compact. Next, please. So now it's not just a matter of state licensure, but in some states, you have to have a Department of Education certification, or you only need that. Let's say one of you wants to start your own company, you might need a business license in a state. Like New York has been like that. Each state, the state may have a different scope of practice. So you could do some things in one state, other things in another state, and it's confusing and it changes. Some of them have their own code of ethics. Some have their jurisdictional requirements. So you have to take these different tests. It could be the same test over and over again, but they want to give you a test. So, it's a little awkward practicing between states. Now, be careful. You have to be compliant with federal law. And one thing that sometimes clinicians fall into is they'll be on a website and they'll say, can anyone tell me what you charge for an hour of blank kind of therapy? You can't do that. That's an antitrust violation. That is because the government wants the consumers to have the advantage of a fair competition. Okay, remember the states regulate healthcare, but the federal government also has some legislation. So it's important not to violate antitrust. Another thing that people can do is they'll say, "Oh, hey George, let's have lunch. How about you take this part of town and I'll take that part of town. I won't advertise in your part of town." You can't do that. You can also say, "Hey George, how about you work with the folks with stuttering problems and I'll work with the literacy problems." You can't do that either. So the government, the fines are pretty awful for this, and it's a criminal offense. Next slide, please. Okay, so now I'll make up a little time here and basically say that if you're going on vacation somewhere to another state, unless you have a state license in that state, you can't practice there during your vacation. If your client goes on vacation, unless you have a license where they're going on vacation, you can't practice there. There's something about the third one that's kind of in a light green, talks about a singer who was also a vocal coach and didn't have a license to practice because they didn't have a master's degree. Now all of a sudden they have a master's degree and they say, "Well, I don't need a license because I did this kind of work before I had my master's degree." That won't work. That's reframing. Okay, that isn't a good thing. The only time that can happen is with foreign dialect. So also, let's say you want to practice in another country. It's cool to do that, but they all have different requirements. And there's no central repository for that right now. Next slide, please. Now, as a fundamental, we have to be concerned about privacy, and security. Where's your client right now? Okay, did they go to the neighbor's house? Well, what if they have an emergency? How are you going to call for help? You know, they can have a stroke, they can fall off the chair, the dog can bite them. There's all kinds of things that can happen. You have to know the address of where the client or the student is right now. You need to know the emergency number if they're in a different state or locale within your state. 911 is not going to work if God forbid George falls off his chair and I say, "I got to call 911 in Utah." That's going to take a while for my 911 to get a hold of his 911. But there's specific phone numbers like the fire department and the emergency. You want those phone numbers available for every client. When does the session end? Well, when the client leaves the room, not when you leave the room. You're responsible if you started up the software. Who's in the room? Okay, if there's someone in the room that can't be, like a minor or someone that doesn't agree to be videoed, that's not a good thing. And that's why in schools, doing this in a school, you often have to be in a private place or have everyone in agreement in the group that it's okay to be videotaped. And then you want to have the video destroyed. Okay, you don't want this stuff stored. And that's why you need to know that the software company you're using is really sensitive to this. Who's keeping the video? Okay, who keeps this video? How long does it stay? Could it be sold to a third party? Could it go to another country internationally where the laws don't govern privacy and security as much? A lot of people say that they want a technology company that's HIPAA compliant. It's not the company that's compliant, it's the user. Generally, you need a team of people in a school. You need the IT person. You need the, you need the therapist. It's a team, an attorney oftentimes to decide what constitutes compliance and how do we manage incursions. Next slide, please. So this is a great article for you. It's free and it has a checklist. And it makes you think a lot differently about privacy and security. There's so much more to it. Email and faxing and phone, and who can hear your answering machine or your answering service on your phone. Next slide, please. So also a fundamental is that you're going to be needing well-trained e-helpers that could, whether it's in the school to get the child to to the computer and turn it on and make sure things are working well and have the materials ready, or in a home. It may be that you or your staff have to train these individuals, and you're responsible for them. Okay, we are responsible, at least in my profession, for our assistants. So we're legally liable for them. This is a great resource for all the different functions that an e-helper can provide. And again, it may be a family or it may be a professional. Next slide, please. So we know technology can fail. We had we had some issues about that today. And sometime, a month or so ago, a tree fell and took out my internet, the phone, everything. It took out everything. I had to drive to a delicatessen to get back online with my students. Our computers can fail. And then there's like busy times, which I think might have happened today. Cyber Monday or certain times of the day, the internet becomes overloaded. Next slide, please. So we have to plan for these challenges and have redundant materials. It's good if there's materials right with someone. For example, before today, I printed out this whole long presentation because I wanted the materials in front of me in case we had a really catastrophic failure. And what do we do when it fails? What's our channel to communicate with each other when it fails? This was a really good protocol here today that we could move into a different technology. Next, please. Okay, so now this will be fast. All right, we're getting towards the end, but I want to talk a little bit about teletherapy. I was told that you need to know where the evidence is. Next page. Next slide, please. Thank you. Okay, so now the research is looking pretty good. This is a website that you can access research. It is it's updated constantly. There's evidence maps, but we do need more research. What about how do we select patients? There's no hard and fast rules. I wouldn't discount any population. Some people don't want to have kids on the autism spectrum do this teletherapy. Some people say, well, they do much better on this particular modality. Don't count out anybody. And we need to, there's certainly not research about hybrid care. Training, how much training does it take to become good at this, or even self-training? And then what's the economic impact on the workforce? We don't have a handle on that yet. Next slide, please. So this is a comprehensive reference, and it has many, lots of stuff on there for training and privacy and security. This is a very rich site, and it's really free. Next, please. Okay, here's a few books that'll help you. Todd Houston has a book on telepractice. It's a few years back, but it's, some of it would be dated, but it's still pretty good. Gives you the range of telepractice. Next, please. These are disorder types. Every disorder works with telepractice. There's articles that I'd be able to point to. You can search for them, look for them on the ASHA website or on PubMed. Next, please. Early intervention. I have friends in occupational therapy. They're doing a lot of earlier intervention, and family and speech language pathologists are too. Next, please. We're working with Tele-AAC. This is a book that we just published last November, and that is, how do people, if let's say your clinicians are working with kids with augmentative and assistive technology, what are some of the options? Next, please. And teleaudiology, you can do anything on audiology because it's computer-based. So as long as there's equipment available, like computer-based equipment, and usually an aid available, most everything could be done. Next, please. And there's a great book. I stumbled on teaching a doctoral course on telepractice for audiology. It turned up all the audiologists came into the course, only one SLP, and I learned along with them. This is a really good book. Next, please. So teletherapy post-COVID, it's expected to thrive. And we're going to be much better at it because we've had this crash course experience in it. I'm very optimistic about it. I'm very optimistic about companies that have a soul coming into this workplace. I think it's a good thing. I'm not anti-company. If I were in this situation right now doing therapy, I'd want to be affiliated with a company, not doing all that billing stuff on my own. Okay, so I hope this was helpful. And I appreciate eLuma put no, they didn't put any, like Dr. Fauci, they didn't put any limits on what I could say. Obviously, I've spoken my mind from my experiences, and I really appreciate that. I think that's the strength of the company. So George, thank you so much for having me. Thanks.
Yeah. Thank you indeed, Ellen. This was a wonderful presentation. Technical glitches notwithstanding, we want to thank everyone for being patient. Obviously, we're a little bit over, but Ellen, if you have a few minutes to stay around to maybe ask a few questions. If any of you have questions, please feel free to put them in the chat.
That'd be
I
great.
myself would be happy to start with a question of, Ellen, obviously, you're privy to a lot of the research. I came across your name just looking at some of the research. One of the things that I'd like to ask you is, obviously, there's a lot of favorable research, and to the point that you made in your presentation, most of it's positive. So I guess we always have to temper it with a grain of salt. I'd like to know, are there populations that you've seen in your research that do better than normal with the teletherapy, and are there populations that you're seeing? And obviously, the research is still unfolding, but are there populations that perhaps don't respond as favorably? And maybe let's focus in on the domain of speech, which is your particular area of expertise.
Well, again, people do not often publish their negative results, so they don't bother to write them up. There are some populations you'll see scattered articles where it's more effective. It's hard to generalize to a population, but I think what's happening in the schools, or that's I would say that's a favorable. Those are favorable outcomes. There's some that still require a lot of specialization. Like if you're going to evaluate swallowing, you have to be an expert in swallowing. You can't just be. It also depends on the clinician, what their skills are. So if I were to do work in one area that I'm not trained in, the results may not be as good. It takes a very well trained, just like you would match expertise to the client. I think it's really important. So I think it's evolving right now. I know, Dr. Townsend, you're on, and it was nice. Thanks for your note. I don't know if you're muted. You're muted now, but I'm wondering. I know you're a purveyor of the literature. I'm wondering if you have any sense of that.
Just asked to unmute, Dorothy. Feel free to chime in.
Great information, Ellen. Thank you so much. I would just like to say, from the clients that I work with, my articulation students have made tremendous progress because they are getting biofeedback the entire session if they have their cameras on, because they're able to see themselves, and it's like sitting in front of a mirror. So they're getting the model from me, and then they're able to look at themselves and put their articulators in the place that they need to, whether that's with cueing or they've learned to physically cue themselves if necessary. But my articulation students have done great. I would agree with you when you say give everybody a chance, because they may surprise you. I have several autistic students who have autism who have done fabulous with this model. And that really depends on, who their support system and e-helper is on the other side. But I would agree with you. The one thing I would say is the telepractice is only as good as the clinician. You've made that statement several times. If a clinician doesn't believe in telepractice, it's not going to be successful.
That's right. That's really, those are great. Thank you for that. I have a friend who does, Karen Golding Kushner, does a lot of work with kids with cleft palate, not to change their mechanisms to make them better, but let's say to eliminate glottal stops, for example, or some speech sound articulation issues. And sometimes she tells me she can't really hear the patient very well, and then she'll ask for an in-person visit because
Mhm.
resonance may not be easy to grasp online.
So
That's true. And with those students that I have difficulty hearing, I always pop on my headset because that really improves the sound on my end. Not necessarily how much they're projecting, but it gives me a clearer picture.